For the next session on potential barriers, I once again welcome senior fetal medicine expert Dr. Khurana to coordinate the session. And also with him, I request Technico's Professor for Biomedical Engineering and Fellow, St. Hilda's College, Professor Alison Noble, to jointly coordinate the session with Dr. Khurana. Over to you, ma'am.
Thank you. Ashok, was you going to begin or would you like me to open?
Yes, we'll go right ahead. Thank you. And I would like to welcome all our attendees to this unique point of view, as we have preferred to call it. It's on future prospects of artificial intelligence in healthcare, how to prepare for it, and equally importantly, the discussion of potential barriers. And I would like to thank Professor Alison Noble for putting together the framework for this discussion. We have three panelists. We have Professor Aris Papageorghiou, who really needs no introduction. For those of us who are not in any intelligent field, but come from a diverse, rural, uninformed background, let me tell you, he has learned how to brilliantly divide his time between St. George's, London, as Professor in Fetal Medicine and Obstetrics, and also as Professor of Fetal Medicine and the Clinical Research Director at the Oxford Maternal and Perinatal Health Institute. And he is completely familiar at the same time with basic sciences, clinical epidemiology, trials, knowledge transfer, and his major research interest in the use of artificial intelligence in pregnancy imaging and screening, which he's been working on for several years now.
Okay, I think we've got a disappearing co-host here. Shall I just take over then until he returns? So Aris, I think you're very welcome. I'll just quickly go to our other two panel members. Professor Suresh Seshadri, who's the Director of Fetal Medicine at Mediscan Systems in Chennai, and very much a pioneer in the field of diagnostic ultrasounds and established fetal medicine with an interest in fetal therapy. So you're very welcome to join us today. And then I see my co-host has reappeared. Would you like to continue? Go on. Actually, I'll finish off in introduction. And then Dr. Kandasamy, who's Assistant Professor in the Department of Radiodiagnosis at the All India Institute of Medical Sciences. He's a radiologist by training and particular interest in paediatric and endocrine imaging. And he's currently the Vice President of the Indian Society of Vascular and Interventional Radiology. In all cases, we could do much longer introductions. I'm not going to do that because we'd like to hear people's views as well, but they're welcome to also talk about more of their expertise as we come on into the panel discussion. As this panel is framed about the discussion of the potential barriers for wide adoption of AI in healthcare. Of course, we're interested in imaging. We're also hopefully hear more in this panel session about implications for the India context as well, which is a big theme of our overall meeting as well. And we're delighted to welcome everybody through their expertise in a mixture of AI, as clinical researchers and also practicing physicians. So just to sort of start the conversation, it's a question really that we'll perhaps go around and ask everybody to consider is briefly, could you tell us a little more about your experiences with imaging and AI to date and some of the lessons you yourselves have learned from this? What to date, if your experiences has made a difference and why? And have you been surprised by any of the barriers that you've met that are pertinent to being able to think about using artificial intelligence? And perhaps I could start by asking Professor Seshadri to make some comments.
Okay. Good afternoon, and thank you very much. Um, this question about experiences in AI, because in healthcare sector in India at least, AI is still, we call it in infancy. Several years ago, I started working with very bright students who wanted to do some characterization and working with neural networks. And that actually threw up a lot of possibilities, that actually you could take an ultrasound image and you could extract more information than what is already shown or what we could interpret by the naked eye. And of course, we migrated into looking at the fetal heart, trying to get some automated measurements of the fetal heart, and from still images to real-time images is where we were going, because the main thing we wanted to do was to actually try to automate the most difficult areas while doing an obstetric ultrasound. So the difficult area is always the heart. And we said, let's get the basics, fundamentals, whether the 4 chambers are present, whether the side is equal or unequal. These decisions can be made a little bit more objectively than subjectively. So that's where we've gone so far. And we do have some equipment with as a product. For example, an automated central nervous system examination. You take a 3D sweep, immediately you get all the thing. And while implementing it, when you talk about barriers, I am very surprised to see that in my own institution, when I ask people to come on, we've got a fantastic tool here, go and operate. There's a huge hesitation to use the tool. Well, they said, if I move my probe in 5 seconds, I can get all the sections myself. I've been doing ultrasound for 15 years or 20 years. Why do I need a machine to do that? And one of the questions that was asked is, if I get those automated images, then I have to go and look at each of those images to see whether it has been done properly. And then only I can pass it off. I cannot take it for granted that this will do it right all the time. So this is where the current barrier I see, which is there, and they have to get used to the new workflow, which is there. And especially when people in training, if you start training people in an automated system, when they go back and they wanted to do the scan on their own, then they would have huge constraints on how, because they're expecting the machine to do it all the time. So at least to begin with, we need to be very clear that a good training has to happen, and who actually uses the AI itself is the problem. Is it the experienced doctor who already knows how to do it well, or is the inexperienced doctor who will not learn how to do it well by doing an automated device? The answer lies somewhere in between, I feel, and that's where we need to do. For a certain time, you go to a rural area, you want to standardize and fix exactly how you want to do it every time. Repeatability, that is where I think AI is going to help.
Thank you very much. Do either of the other panel members want to respond to that?
Yeah, hi. I have a couple of things to add. I have been exposed to a few other areas. I don't do a lot of fetal ultrasound, but I've been exposed to areas like spine MR imaging, where I had an opportunity to work with a company who developed an algorithm which can automatically read the MR images and measure the height of the vertebra, IV disc spaces, spinal canal distances, the neural foramen distances, all those areas which are very repetitive and very simple for the radiologist to do. But those are considered as very mundane jobs. And this kind of repetitive jobs takes a lot of time otherwise. So when these kind of repetitive tasks and mundane things are taken care of by the machine, the radiologist can save the time to read the qualitative reading of the images, and at the same time dedicate more time in deciding what has to be done next. So that is one area which I've been exposed to. Also, things like thyroids, automatic, if you do ultrasound of the thyroid, just a sweep of the entire volume of thyroid, the algorithm can pick up the areas and it can grade the thyroids for you, which again helps in management. It doesn't really reduce the time, time of acquisition or anything. It just helps in making it more objective rather than leaving it to the subjectivity of the radiologist. And other things like I'm currently working on something which is more interesting, a picking up of nodules in lung on a CT scan in patients with sarcoma and in patients with any malignancy. And if the algorithm can pick up the nodules, segment those nodules automatically without any radiologist input, and if it can be followed up over a period of time, if it can compare it between 2-3 scans, and at the same time, if it can characterize the nodule, because it's very difficult to characterize whether it is granuloma or metastasis, that's even difficult for the radiologist to do. But if machine can find something new in that, so that is one other area which we are working on. And but when we start with spine MR reading software, initially I thought I was expecting much more from AI. So I thought, I mean, because we have been spoiled from Google and Facebook that every time they work brilliantly well, and we also thought this healthcare imaging AI should also work in the same way. So initially it was not like that, but machine randomly makes errors, which we thought is an easier thing to pick up, but machines make errors in those areas, and sometimes they do exceptionally well. So initially, initial thing was a little bit of we found it little not okay, but we understood the limitations of AI and how it works, and now we know that machines have their own limitations. And the other one important thing which Dr. Suresh also mentioned is that most of the tools available in the current era is all isolated tools. They are not incorporated into the workflow itself. It is not inbuilt into the PAC system. I know systems are mostly proprietary, quiz systems are proprietary, but when you want to when you want the user to use the tool, AI tool, it has to be inbuilt into the workflow of the system. Otherwise, if you want to copy those images, put it in another tool and extract some information from the AI tool, it becomes difficult for the radiologist. So that is one barrier which I think is quite glaring as of now.
So based on what you've just said, I think for me, using machine learning AI for automating tasks, that's been one of the really early success stories. But as you've said, you've had to, I suppose in some sense, humans have to adjust to understand the behavior of the automation is probably what we're saying. And there's been some real successes there. I think Dr. Suresh was talking about another important part, perhaps we could explore it a little bit more, is about the lack of trust in the algorithms or the underpinning automation. So how do we develop trust, and what's missing there? Is it the humans have our expectations are too high, that's been set by other people's expectations, or is it that we need to think a little bit differently about what we mean by trust in automation and trust in would one of you like to speak about that?
I think in some sense, the way of overcoming the barriers, in particular of the trust, is in some way no different for AI as it is for other new or novel developments. And there are many change models, but there's basically 6 things you need. One, you need buy-in from the leadership. You need to address cultural barriers. So, for example, in some settings, a cultural barrier is that only doctors can do a particular imaging method, even if AI would mean that a different cadre of healthcare professional could perform that very well. The third is a sort of cognitive dissonance in a way, or lack of consistency, which means that you're told that the system is going to do one thing and that it works brilliantly well, but actually the reality of the matter is that you don't see it working as well as you expected to. And you know, a brilliant example was given earlier. So, you know, there's a model that comes, it says this is going to solve everything. And when you use it in practice in your everyday work, you find that actually it isn't doing that. So it creates a feeling of lack of consistency of the message of what the tool is supposed to be doing. The fourth element is one needs to have really clear a clear strategic direction or clear communication in some way of what the system is supposed to do. So when we talk about an AI model, most AI models will do a particular task rather than doing lots and lots of different things. And I think sometimes perhaps our expectations as clinicians may be too high to say, oh, this machine, this CT machine, this X-ray machine, this ultrasound machine has AI on it, and expecting it to do everything. Well, in the same way that, you know, you wouldn't expect an X-ray analyzer to look for TB and also lung cancer and also pneumothorax, you would have different applications for different elements of it. So lack of communication and lack of direction. But I think the final one, the sixth one, and I left it last because I think it's the biggest challenge or biggest barrier, is individual change resistance. So like everyone, doctors and healthcare professionals are creatures of habit. The processes have been built up over many years. And when you want to come with a change, there needs to be almost a sort of mental preparation to ensure that you can change your everyday work habit, your everyday routine. And to that specific issue, I think there's always a concern, could this end up being more work for me, especially when you're in a pushed environment? And therefore, I think in our design of AI also, we need to be very clever. It really needs to run in the background and be as unobtrusive as possible, supporting us, but not causing us to have to press lots more buttons or do more things. So I think we could almost see it in summary as any, within a framework of, you know, call it organizational change or any change. I don't think it's different just because it's AI. And specifically to your question, Alison, about trust in AI, I think clearly the thing has to work. But I think if it works and you have been able to address those 6 barriers, I think that's what will then lead to the adoption.
But Aris, are you purposely ignoring point number 7, which is personal insecurity from a professional viewpoint? Aris, what do you have to say about this?
No, I think that's a sort of cultural barrier that I talked about before, but also potentially a personal barrier, which is sort of personal resistance. So yes, you're absolutely right that, you know, as part of individuals' change in resistance, one of the elements there is concerns about, you know, whether it could put your job at risk potentially. And people often ask me about this, and I think, you know, it's we're going to hear about lots of people, but, you know, it has been said that AI is not going to certainly replace a radiologist, but I think radiologists who use AI in their everyday practice are likely to replace radiologists who don't. So it's a subtle difference. Thank you.
And what about just selling and packaging AI appropriately so that it's less formidable to the user? We tend to think, oh, I'll have to look at all these 6 images, that wonderful example that Dr. Suresh gave us, that I have these 6 images, but I'll have to recheck them. But I can train my mind to recheck those 6 images as fast as I do otherwise if I were to do a basic number. So is that truly a problem, or is that just something that's not been packaged in retraining them? Aris,
Suresh, do you want to answer that question?
Yeah. So see, the whole thing is when you talk about trust, the packaging, as you said, if we start pitching AI as just a screening method where it can triage and tell you these patients you need to give more attention, rather than say AI gives you the diagnosis. Once you say AI gives you the diagnosis, it is actually looking like taking over my role, because I am the person who wants to give the diagnosis. Whereas if you say, well, I've seen 6 patients, now 2 of these patients, I definitely need to put more effort because the AI is telling me there's something wrong there. I go and find out what it is, and then I start taking over from there and start. That may be actually a better way of acceptance, saying, okay, there's somebody helping me. It's like my assistant coming and saying, watching the screen, hey, I'm spotting something there. And then you also look at it, yeah, I agree with you. There's something there, we should look into it. So to begin with, at least, they are not overwhelmed with the technology, rather than they're using it as a supportive technology.
I also agree with it completely.
Wonderful, which brings us to the new things. Like, if we were to actually objectively assess progress up to today, where have we reached and where have we not reached? Deva, could you tell us about that in your experience?
So I think in a very short period, there has been a tremendous growth in the field of AI, right from 2012 or 2013, when the CNN was introduced into this ImageNet competition, and that's what is, I think, is the seed point. And since then, in 9-10 years, it has reached a level, and it has reached a level that we are already of whether this technology can replace us, although it's not going to happen in the near future at all. So, and there has been a tremendous progress, and the disruption in this area is imminent. There is no doubt in that. It will happen in another 5 years or 10 years. What I can see is that it will function as a first year or second year resident who will screen the data, and like Dr. Suresh said, that it will pass on the message to us, so that we'll be in control, and we can assess, or we can see the things and approve those things, whether the AI is right or wrong. But this disruption is imminent, so it's a matter of time. But how we as a radiologist or physicians are going to handle this and still maintaining our superiority over AI technology is a question.
I think the basic difference, because whatever Deva said, yes, it's true, but that's for cross-sectional imaging. And the percolation has not been as much in ultrasound as it has been in cross-sectional imaging. And that's a huge thing, because cross-sectional imaging, the machine does the images. So everything is under control. Here, the image is under control of the hand. And when the hands move in whatever fashion they want, and there is a standard by which you should move, and people are trying to achieve that standard all the time, but many of them are not able to achieve it. So that's where the big difference between ultrasound and the other imaging modalities are there. So I think so in my opinion, if an ultrasound machine, for example, because it's been around for quite a while, if I want to interpret an image, what is the image I can interpret with confidence, and where does confidence comes from? If the AI tell me this image is good enough to be interpreted, I'm still okay with it. Classical example I can give you is nuchal translucency. We know the high variability in the way people take nuclear translucency. And if I take a mid-sagittal section, which I believe it's a mid-sagittal section, and if the machine says, this is not mid-sagittal, you are 20% off, then I won't interpret it. At least I'll say, okay, let me try to get one more image till I satisfy the machine before I can do the interpretation. That will be a very good thing to do.
Yeah, guiding the sections like taking the head circumference, abdominal circumference, femoral length, everything can be guided based on AI. When you start measuring, the machine will automatically should say that, yeah, the confidence level is this much, whether you want to proceed or not. That's also a.
So your question, Ashok, is about predicting the future, which is really dangerous business and technology in particular. I like to think of Steve Ballmer, who was Microsoft's CEO, who said that the Apple iPhone is the most expensive phone in the world, and it's not going to appeal to anyone because it doesn't have a keyboard. So it's it's that kind of trying to predict what happens in technology is very, very difficult. But I think there are some signs, and one of the signs is exactly as Suresh has outlined in cross-sectional imaging. So if you look at X-ray radiology, for example, there are already systems today that will prioritize, for example, the reporting clinicians' X-rays. So ordinarily, a radiologist will come in the morning and see the X-rays that were taken on the previous day and in the order that they were taken. So it start with a 9 o'clock X-ray and finish with a 5 o'clock X-ray. But a 5 o'clock X-ray happens to be, the urgent X-ray with a pneumothorax. What the AI algorithm does is simply reorganize the list. So it's not going to change anything ultimately at the end of the day, but the X-ray that's of most clinical relevance is reported first. In MRI, for instance, or in CT, things are highlighted for the reporting clinicians to look at in particular, pay attention to particularly. But that is very, very different in ultrasound. And I think that there's a recent report from Signify Research that shows that AI in ultrasound hasn't seen as much pickup. But I would actually say, well, is there that much there for it to be picked up? There aren't that many tools available right now. There are tools that will automatically place calipers on images by GE and Samsung and Medison and others. There are tools that will automatically label images. So Samsung has a pretty snazzy tool that will label your 4 chambers, for example, when you're in the 4-chamber view, when you've frozen the image. Quite how useful that is, I don't know, but it's there. I think more importantly, GE has a software on the Swift system that does a checklist of quality and completeness. That's stuff that we developed together with Alison as well. By declaration of interest.
And so the whole notion of fetal analysis is probably one of the most challenging in the medical imaging field. I like that. I work in that. I've chose it to dedicate many years of my life to look at the problem. But it has a lot of challenges that you just don't see in other areas. And that makes it very rich actually to explore machine learning. But getting then the solutions into the clinic is to the point that they're robust enough. There are a lot of extra challenges that you have to overcome. So I thought I would just add in the engineer's perspective on this too.
And I'd also like an input on one more thing, that if I'm not getting suboptimal images and my machine is helping me to get those, and then I'm able to identify that, yes, I see the standard planes or I don't see the standard planes. That is not difficult really, and is happening already. Now that is also inexpensive technology on most of the vendors today. And I think that will really be the greatest achievement that we have so far. What do my panelists have to say about that? This semi-automation, semi-quality check that we already have from the bit of work that we've done so far.
Sorry, who did you want to comment on that, Ashok?
I wanted to comment on that from Aris, because he's familiar with both ends, the manufacturer and the producer of data. That if my equipment is telling me that this section is suitable and it's reconstructing for me without me having to make too much of an effort, I think that is something that we should accept far more easily than we're willing to accept now.
Well, I think you're right. I think the crucial element in a way is how well does the system work, and I suspect that the adoption barrier will become lower and lower as systems work better and better. So you mentioned semi-automation. Absolutely. Going from nothing to full automation is always going to be a big step. And having a step of semi-automation may be useful not only from the perspective of product development, from the engineering perspective, but may also be useful from the point of view of adoption. The barrier to go from nothing to full automation is quite high, and people, may feel more comfortable going through a step of assistive technologies. But I think the sky's the limit in some sense. Think of, for instance, now that we're able to extract, now that we're able to identify optimal imaging planes, for instance, from real-time ultrasound, what's to stop technology taking 3D volumes, for instance, and extracting from those the optimal imaging planes, analyzing them appropriately, highlighting areas of concern, etc. So apart from this small first step of automating the quality or the assessment of the quality of the images, I think this is a prerequisite almost to lead to further and further developments in this field.
And Deva, what would you think? Well, now that we go beyond this stage, Dr. Suresh Seshadri basically mentioned about the fact that this business about decision making, which means radiomics and a histopathological diagnosis, for instance, like we have in tuberculosis of the chest X-ray. How far are we from that in your cross-sectional field, for instance? How acceptable is radiomics so far?
Yeah. Sir, the field of radiomics, again, is based on traditional machine learning algorithms. And whenever you use radiomics on any cross-sectional imaging, it throws at least 300, 400 parameters for each ROI. And most of them are redundant, and those are not very consistent across scanners, consistent across different reconstruction methods. So I'm very skeptical, although we have published a few papers on radiomics on renal cell carcinoma and a few others, but we are quite skeptical that just radiomics alone cannot be a robust method to characterize unless we put in other dimensions into it. So otherwise, currently, even CNN or neural network based AIs cannot work on multiple organs at the same time. They can focus on chest and find out whether there is fibrosis, tuberculosis, or something else, or pneumothorax. And they can work on liver to find a lesion, or whether it is cyst or a solid lesion. But when you look at a patient as in total, and if there are multiple organs involved, AI is not matured enough. Now in the current scenario, AI is not mature enough to compile all the characteristics at multiple locations, especially in multi-system disorders. Currently, AI is not to that level. So decision making is not currently so robust if you depend on AI, but definitely it can replace repetitive tasks, replace measurements, replace things like measurement at particular plane, or things like you discussed earlier. So decision making is still a level higher. That's what I think.
And do you think that regulation of all this will be hampering our progress or facilitating intelligent progress?
I think regulations are quite important because currently what even in physician's mind or in public mind, there is a lot of positive things about AI, and this will be there for some time. So if you consider there are multiple AI tools coming up, and all of them are not very efficient or not very good. So if over a period of time without any regulations, if some of the tools fail and it eventually hurt the reputation of AI in total. So regulation should be there. It should be all AI tools should be evaluated like medical devices before they are put into clinical usage. So I think regulations should be there too. Eventually it will benefit the specialty.
And Professor Suresh, we have three types of regulators. We have the scientific community and people who have a scientific background. And then we have the progressive bureaucrat. And then we have the redundant, frustrated bureaucrat. How do you handle them on a daily basis?
Well, see, if I'm talking like an end user, I allow that headache to be taken care of by the provider of the equipment, because they go and bang their heads, and sometimes they come and say, "Sir, I'll give you a simple example. That's a medical device which I ordered today. They said it'll take you 6 months to come. Why? Because we have still not been able to register it with the authorities. Every equipment needs to be registered with the national one authority, and they are refusing to give registration for this because it is called as a fetoscope. And the moment you say fetoscope, they say you're going to do sex determination. And so they have just kept it in abeyance. When 1,000 other equipments from the same company have been registered, they have not registered them. So I have to wait for at least 6 months, and I'm not sure at the end of 6 months it will come. So there is a huge problem as far as regulation. I agree that regulation is required, but regulation must be intelligent. You must look at the needs of the society. You must take an expert's help to find out what it is used for. And healthcare cannot stop because of regressive regulation policies. You can't prevent healthcare from progressing. And that's dangerous because we are actually putting a lot of people to hardship because of that.
I do think though that regulation also plays an important role in the context of what we've been talking about in terms of acceptability and barriers. Yes. You know, there is a perception, rightly or wrongly, that, you know, private institutes push very hard new technology sometimes before they're fully, you know, cooked, if you like, in order to make a quick buck, and in order to make a profit. And I think having, as medical professionals sitting, you know, on the other side, if you like, as a medical professional, knowing that this system has been approved by the FDA, has been approved by, you know, has CE marking, has some kind of regulatory stamp, gives me, or at least removes that worry that it might not be doing what it's supposed to be doing or be harmful in some kind of way. So, you know, I do think there's a balance, Ashok, in between, you know, over-regulation, but also giving that confidence to the medical practitioner to say, well, yes, this is going to do what it says on the tin because the regulator has approved it.
Can we just look at a little bit other end of the spectrum and say, can we use AI more effectively as a training tool first? As a training tool, you do something and the AI tells you did it right or wrong. And that will go a long way in improving the quality of training. Where regulation can be a little lesser than giving diagnosis.
There are at least 3 vendors that I know of that have now added onto their ultrasound scanners a cartoon of what is being seen, a cartoon of what should be seen, and it labels it only when it is absolutely correct.
Correct.
So that would be a great thing to train.
Yes.
But Dr. Suresh, I was wondering, for people who are not trained, yes, and I want to identify some of the great obstetric killers, for instance, say a breech versus cephalic or placenta previa versus not placenta previa. and then be able to train people who are at a very basic level and may not even be within the medical profession to actually recognize that on the basis of AI. I mean, our local Indian PCPNDT Act aside,
Yes.
where do you see this going if we didn't have a sort of pseudo regulation where the emphasis has been in the wrong direction? If it was in the right direction, then it would really help us to triage our patients from being able to go back to her village to deliver very peacefully versus being referred to a tertiary center or a secondary center.
True, but that would actually mean, if we are meaning that that person need not know anything at all, they just need to put the probe and the machine will do everything without thinking. It can be a village health nurse or somebody who can put the probe and then the machine will tell you everything. That I think will be stretching it a little bit far. And there has to be, I believe there has to be a little bit of training. We cannot do away with the training completely, but AI can reiterate the fact, well, I'm seeing something here. The AI can tell you, okay, this looks like a placenta previa or whatever. That will be important. I would not risk somebody just taking some probe and putting it on the abdomen and the AI telling something and then saying, okay, now you go and do something. That will be completely unacceptable, at least from my side.
But if I have the right technology and the right mindset, cultural mindset, if all worked out right, do you think this is going to be possible in 3 years, 5 years, 10 years, or 20 years?
Without a doubt. See, the thing is, instead of using the word cultural mindset, we will say acting responsibly. Acting responsibly, because that is where ultimately the issue is. It is somebody has to take responsibility. What if a medical legal issue comes up? Is the AI going to answer it, or is the person who put the probe without knowing what is there, is they going to answer it? That's going to be a huge problem. So we need to be tread very carefully in that area. But in 5 years' time, let's keep it like this. What is there are 30 million births in India. Okay, every single woman needs at least 3 ultrasounds in pregnancy, out of which we are still going to say the second trimester scan is the most important scan. Now that second trimester scan, we are saying everybody, you must take 27 sections to ensure that this examination is complete. I'll go one step beyond and saying, I'm actually thinking, while which might happen maybe sooner than later, is the concept of fetal insurance, right? We are doing a health checkup for an adult, and this health checkup, your health is declared to be normal when the insurer comes and tells you, okay, this is the premium you need to pay. In future, if you have an ailment, I'll reimburse your expenses. Now, the same concept, I want to drive it to the fetus. If I do a second trimester scan and call it as normal, I tell the insurer, here's a normal scan, and I want the fetus to be insured. In case at birth there's a problem, then I need an insurance to happen. I call this as fetal insurance. And the insurer has to be sure a quality ultrasound has been done. Now, where do I go for this? Because you know the skill sets are extremely variable across the country. When somebody comes and asks me, can you tell me in Chennai or in Delhi, how many people can do a good targeted scan? I mean, I can't answer that question. It's impossible for me to answer that question. So that is where this AI comes. If it says, you have taken all the 27 sections, okay, and the checklist is being completed by the scan, because unless you complete, the moment you complete the checklist, the machine actually can print out a certificate saying all 27 sections done. That's all, right? That would mean a lot. And going forward, I see it as a great potential. Yes. Just the completion of all the scan. The interpretation is different. Just the fact that I've seen the limbs are there, the head is there, the abdomen is there, then we know that if there's a major thing, the doctor would have identified it anyway.
Alison, we have to have your inputs on this, and then please throw some questions as well.
Well, I was also wondering where our attendees have gone. It'd be great to have some questions that we can ask from our attendees. So anybody, one pops up as we speak. I'll maybe come to that when I've read it. I first got a slightly different question. We've talked a lot about people's views from the clinical side. We've not talked at all about patients and their views of AI. And I just wondered whether the patient attitudes towards, and it comes back to maybe trust in AI, is whether anybody would like to share their views on how patients view about decisions being made where a tool has AI in it, and their own experiences of that. Who would like to take that question?
I think I'll try and answer this question. Even now, patients as a general public, they have a good understanding or good reputation. They have good thing about AI. They always think that AI should work better, and they think AI has some superhuman powers, and they should work better than doctors or physicians. This comes from the same background of Google and Facebook. Using AI has done wonders which very difficult for a human to do. So with this background, patients generally have this feeling that if something is AI, if something is HD, if something is of some buzzword, they think it is going to be better than the ordinary scan or ordinary thing. And at the same time, even the media, which it's very difficult to find a negative or a limitation of any AI technology in the media, mainstream media. So everything is now positively projected, and so general public also feels the same. Patient also has some idea that, yeah, this is AI, I should go for AI. Even in camera, mobile phone camera, if there is AI, we'll go for this has some AI camera. Whether it does anything or not, AI is the umbrella terminology, so still believe it. But at the same time, we should also tell and let the patients know the limitations of the technology. Unless we let them know this can go wrong, even if it goes wrong, nothing to worry. And we are there to supervise it. We are there to take a decision, because AI is not going to take any decision for you. So we have to discuss and make them understand the limitations of AI, and at the same time giving more confidence that physician is always there or a surgeon is always there to finally decide what is better for you. So I think this needs to change, because currently it's all very positive for AI, but we need to send across this message to the patients that there are a few things which that cannot do, and we are there to help.
I guess here there's maybe a difference between AI for automation and AI for decision making. And we talk about the future, the AI for decision making. Humans are maybe a little bit more want to understand a bit more why a computer would be making a decision. Do any of you have experiences of the decision making side, where you think that you have had the patients challenge that? Has that happened in radiology, for example?
No, we haven't had any. Haven't had any experience related to this. No. We are using it as a tool to support our decision making. We have not exposed directly the algorithm to the patients. We have not discussed those with the patients, because this is all technology is still in experimental stage. We are using it for our own purpose, testing it most of the times, developing it. So I don't have any experience on that.
I think there's also a big difference between assistance, isn't there, and being part of a decision making versus fully automation. I think I'll just briefly go to the comment that was made. This was from Rahul, who says, can we draw, which is very relevant to our ongoing discussion, can you draw an analogy with pilots and plane automation? Fly-by-wire was controversial. It takes away pilot expertise. In fact, playing computers have caused some crashes, but people generally agree that humans make more errors. Can we say the same for AI medicine? There will be errors, but maybe much fewer than with humans. Any response from the panel?
I think a very fine balance has to be drawn, but it's a very beautiful question. A very fine balance has to be drawn between how much we can push AI to how much the human being control is there, at least as far as patient decision making is concerned, at least for now, till we get really fantastic technology over a period of time. The human has to appear to be in control. They have to appear to be in control, and so that the human being in front of me feels very comfortable. Here's a doctor I have come to. He seems to be in control of the situation. Whatever tools he uses for himself. But when he talks to me with conviction. I think that's very important.
Yes, but coming back to, we have a couple of minutes. Yes. About one of these tools in gynecology, for instance, when we do ultrasound in gynecology, and I have these markers for prediction of malignancy in a mass, in a lump next to the uterus, which means it's in the ovary. And I have very little experience, and I use the ADNEX model, for instance, and I have very good experience, and I just use my expertise. If I were not to use that model, I would be correct 30% of the times. And if I do use the model, I might be correct in as many as 76% of the times. And that's been validated. So I think it would truly be useful to realize that everything has a place and everything will evolve, that we should therefore have semi-automation, automation, but we shouldn't forget about decision-making. And we have to encourage people and practitioners to have an open mind.
Ashok, I think what Suresh said earlier about responsibility and action is so important in this regard. So who takes ultimately responsibility for the decision for your ovary? It is you who makes that decision, aided by a computer system. The computer system does not make the decision at this stage. And I think the discomfort from walking onto a plane without a pilot has meant that pilots are still there on the plane, although they're not really necessary anymore. And I think that the same will be true in medicine. The last place I think any of us want to be in is a situation that I find myself in, having for the last 2 weeks on every nightly basis been uploading documents to a bank in order to get my wife as a co-signatory in an account, and her papers are not being looked at by any person but by a computer algorithm, and keep getting rejected for a variety of reasons. There's no one to speak to, and it's this kind of worry, I think, actually ultimately, that many practitioners, I think rightly have. So AI will be there. AI will be used. It is an extremely useful tool. You mentioned one example in gynecology, and I think it will become increasingly useful, but it is absolutely crucial in my view that human interaction between the patient and the clinician remains and actually can be enhanced, because the boring and repetitive tasks can be taken over by a computer that computers are actually better at. And the computer, the algorithm, puts in front of the clinician all the relevant information for the clinician to make the right decision, the best decision, and spend that extra time that was saved on better patient communication, counseling, and taking decisions together. That is my vision of how this should work.
We should see AI as augmented intelligence rather than autonomous intelligence. We should function mutually beneficial to each other, AI and the physicians. So we should use it as augmented intelligence, not as a standalone autonomous intelligence.
And before I hand the floor back to Professor Alison Noble for thanking all our panelists, one quick question. If I'm out in the remote area and AI can help me and I have nobody else, how smart is that?
I think no question, that's the best.
If if there is a facility available when no one is there and AI is there as a friend, consider AI as a friend and leverage it to the best interest of the patient.
Yes, it's available, it's inexpensive.
Yes, definitely.
Two fabulous qualities.
Why not? Something is better than nothing.
And that was one of the questions in the chat box that I hijacked and took credit for myself. So Alison, to you for winding up and thank yous.
Thank you. Can I just thank very much our 4 panel members. We've had a very diverse conversation, and I very much thank you for your personal views of your experience of using AI and your thoughts on where things might be going in the future. And I'd also very much like to thank my co-host for this session as well. It's been a very enjoyable conversation. Thank you.
Thank you.
Thank you.
Thank you very much. Thank you.
Pleasure being here.